I'm Patricia Dane, cardiologist. I'm here with Dr. Warwick Jeffy, interventional cardiologist from Ascot Cardiology. So Warwick, I hear that we've got some new electrophysiology services available at Ascot Angiography. Can you tell us about that? That sounds really exciting.
Yes, it's a great breakthrough for us. We have a new electrophysiology laboratory that's ready to go and has done several cases here at Ascot Angiography. Using this, principal user is Dr. Andrew Gavin, who's a cardiac electrophysiologist based at North Shore Hospital, but also working widely throughout Auckland.
So what are the procedures we are performing there from an electrophysiology point of view?
Well, we're doing ablation procedures, pacemakers, etc. And I'd like to really talk about what sort of patients we want to be doing these procedures on, and generally the indications for them.
So clinically they all have palpitations.
Yes.
And do we need to see all the patients with palpitations?
No. A lot of patients with palpitations can of course be managed in general practice, usually those with the ectopic beats and all minor forms of arrhythmia. Most of those that end up with the cardiologist are those that are more symptomatic or have very frequent palpitations.
Are those the supraventricular tachycardia patients and the atrial arrhythmia ones that we are interested in?
Mostly, yes. So most of you will remember supraventricular tachycardia. That's now terms not used so much. We usually precisely define the mechanism of it because that allows us to work out how to fix it. But these patients generally with narrow complex tachycardias, most of the time they are either managed with simple reassurance, a Valsalva maneuver to try and get rid of it, or if it's intrusive, these days they have an ablation procedure. That's because taking drugs for a younger person lifelong to prevent these atrial arrhythmias is not very attractive, often a lot of side effects. And the ablation procedures for SVT and etc. are relatively safe and very effective.
So what are the success rates of these procedures?
Oh, very high, mostly about 90-95%, and those people that do get a recurrence, they can often be treated with a second procedure. Now that's not true, of course, for the more complex forms of arrhythmia that we're going to talk about in a second.
What about the more complex patients with atrial fibrillation or atrial flutter?
Okay, well you bring up an important point there. A lot of you GPs think atrial flutter and fibrillation are the same thing, but they're actually two quite different arrhythmias. Flutter is a much more organised, regular arrhythmia. The majority of patients with flutter that arises from the right atrium, that is something that is very suitable for an ablation procedure if simple antiarrhythmic drugs fail. The success rate's high and the risk of doing it is pretty low.
Right. So that's for atrial flutter. What about atrial fibrillation? That's a lot more common than atrial flutter. How do we manage that?
Well, most patients with atrial fibrillation can be managed with preventative drug therapy. And those that can't, that's where we consider the ablation procedures. Now, for people who've got atrial fibrillation permanently, the ablation procedures are really not very useful for that. Mostly they don't work very well. So we're generally talking about people who've got atrial fibrillation coming and going, or people who've had it for a relatively short period of time.
What about those patients who are not very suitable for AF ablation? What do we do with those patients?
Well, those patients either have to have rate control with drugs, and in some people it's very difficult to control the rate, or the drugs that they take are too toxic, and then those sort of patients can be considered for electrophysiological procedure. What we do there is destroy the bundle of His so that electricity can't get from the atrium to the ventricle, and then have them dependent on a permanent pacemaker. So you've got to put the pacemaker in first, and then you do the bundle of His ablation a short time later. And that procedure is now available at Ascot Angiography.
Okay, tell us, how is the procedure performed and what's the complication rate?
Well, I'm not a cardiac electrophysiologist, so basically you put some tubes into the veins in the right groin. You have to access the left atrium because that's the area where the atrial fibrillation comes from. The pulmonary veins are all isolated because that's where the triggers for atrial fibrillation come from, and an injury is inflicted on the mouth of each of the pulmonary veins, and it can either be done by heating them up with radiofrequency or by cooling them with liquid nitrogen at -70 degrees. and that creates an injury and hopefully stops patients getting fibrillation. Now, it works about 70 or 80% of the time in highly selective patients. Some of those people you've got to do it a second time to get an enduring result. The whole problem with the procedure, of course, is that there's a risk involved. The heart can be perforated. There are various other rare risks. Even though the risks are low, they're pretty bad or serious risks. So we're never going to do one of these ablation procedures in someone unless they're pretty badly affected.
Okay, that sounds very exciting, Warwick. And thank you very much.
It's been a pleasure.